It is noon. I will keep an eye on the waiting room, but I don't want to hold back. I want to respect people's time. We do have a little bit longer for the session today than we had last time we had the session. We planned an hour and a half today, so we will have time for questions at the end. If you can throw your questions in the chat box as we go along, that'll be helpful. Rachel and I will keep track of those. And if they're urgent or immediate and quick questions, I'll throw them up to Dr. Haskins. If they're not, we'll hold them for the end unless you decide you want to do questions partway through Dr. Haskins. So if you're here for the cultural competency tune-up, you are here for the right reasons and you're in the right place. Like I said, today's session will go until 1:30. It is eligible for OASAS renewal credits for all of OASAS's credentials, as well as social work credits and licensed mental health counselor credits. What else? I do want to send a special thank you to Conifer Park and Arms Acres, who are part of Liberty Management. They reached out to us a while ago and said they wanted a staff training on cultural considerations with problem gambling. And so we thought Dr. Haskins was the best person for the job. So thank you to Conifer Park and Arms Acres. They are on our training session today, as are a lot of their staff for professional development. And we'll give them some time to chat at the end about their services. So if you want to learn more about Arms Acres and Conifer Park, they are here. I think Nora is here and Michelle may be here as well. Nora, Michelle, if you can just pop your information into the chat box so everybody can have that, that's great.
Sure. Thank you.
You're welcome. The slides for today are on the resources tab on the course page. So you'll see the syllabus tab. Right next to that is resources. The slides are there. We'll also be adding some Conifer Park and Arms Acres information. So in case you guys want to connect with Arms Acres and Conifer Park post-event, you can do that as well. Nora, did you or Michelle want to say something briefly?
Yeah, I think Michelle did.
I don't know if she's on. I don't know if she's on, Maura. Looks like it's you.
No problem. I just wanted to say thank you for this collaboration. I find this a very exciting event, and its information is very, very important. Just briefly, Arms Acres, Conifer Park, Liberty Behavioral Management, we provide inpatient, outpatient services for SUD. So I don't want to take up any more time. I will put in my information in the chat. So thank you all, and on with the show.
All right, I'm going to hand it over to Dr. Haskins again. If you guys have questions as we go along, put them in the chat box. I'll stay on at the end to answer questions about Arms Acres and Conifer Park. They'll be here as well. I'll also give a little tutorial on how to get your certificates at the end in case you have any questions about that. So without further ado, Dr. Haskins, it's all yours.
Thank you, Jamie. Thank you, New York Council. And I want to thank the two collaborating agencies and all of you for tuning in today to our session. And I thought this would be a really cool title. I'm always trying to shake things up, mix it up, and be creative. But as Jamie said, let me just give you an introduction to who I am. I'm Deborah Haskins, and I am a retired pretty recently, since 2019, scholar and practitioner and counselor educator, and have spent my career training psychologists to be folks who are planning to go into social work from undergrad. My last journey was leading 3 professional counseling programs at Trinity Washington University. So I am an educator, and I am also a gambling counselor, internationally certified through the ICG-CCB board. I also am the president of the Maryland Council on Problem Gambling, and I've been the president of this nonprofit since 2011. And as you all know, we're committed to what we call the 3 A's, providing gambling advocacy for wellness, also providing assistance to people who are in trouble or experience harm as a result of the gambling and other co-occurring challenges, such as substance abuse and mental health challenges, and also providing them awareness, increasing public awareness. So an example is, I was telling Jamie that the Maryland Council on Problem Gambling, we are doing a event with NCPG that will be showcased in November, that is produced by Urban Radio. And this will be a pretty much like probably a 30-minute community wellness session. And we talk about sports betting as well as gambling addiction and problem gambling, high-risk gambling. So I'm really happy to be here. And I'm the owner of Mosaic Consulting Counseling Services. And what I've been doing since the early 90s, really, particularly, and then to the later 90s, is to really focus on helping practitioners like you and me and others understand how to integrate culture as well as social justice in our mental health and community wellness. I'm a big community wellness person. And the reason being, and I'll be talking about this morning, is because we only reach a small percentage of people. So this session, as you see, is titled Need a Cultural Competency Tune-Up? Updates. I'm going to be sharing a couple of updates in particular that you can use in your gambling disorder treatment, as well as your substance abuse treatment, your mental health treatment. And I want to offer you some ideas of how you can also be doing community wellness more broadly. And so I'm happy to be with you here today. So let's get started, and hopefully we won't have any issues with advancing the slides. Okay. All right. So the objectives for today's session, I want to introduce to you just a short review of 2 updates in cultural competency, specifically one model called the multidimensional model for how to broach culture. And this is some research by Dr. Norma Davines, and has been updated in 2020, actually. This research program has focused on how are we as practitioners comfortable with broaching culture. And a quick example is I'm working with an intern now that I supervise, and this is an Asian descent intern in a counseling program. And the intern is really still needing some ideas of how can she increase her own confidence of how to explore culture. And the question the intern asked me is it appropriate to ask during the referral time? So when they call for help, is that an appropriate time? And I said, absolutely. So we're going to talk about the broaching model. And we're also going to I'm going to introduce you to, I love Dr. Carolyn Tucker and their team that's called Patient-Centered, Culturally Sensitive Healthcare Model. And I'll talk a little bit about that specifically. And then the goal is to apply these 2 updates to disorder gambling treatment, prevention, and mental health services. And then I want you to explore some considerations of what I'm hoping are some new ideas in terms of gambling wellness opportunities that you can be doing regarding psychoeducation to cultural communities that are quite diverse. All right, so let's go ahead and move along. This is the agenda that I have just very briefly. I'm going to introduce you to the problem and the need for updates in disordered gambling for about 5 minutes. Then we're going to do a quick poll that Jamie's going to help me with. And I want to introduce to you a cultural competency assessment that you can use with your agency staff as well as with yourself if you're in private practice like me, or if you are a member of an agency team, so that you are continually learning and committed to cultural competency. And then we're going to spend about 20 minutes looking at the multidimensional model for cultural broaching. We'll spend another 20 minutes, hopefully, on the patient-centered model by Dr. Tucker and team. And then I'm going to just briefly describe and give you some ideas and some resources for wellness for about 5 minutes. Now it says here Q&A 5 minutes. The Q&A is actually going to be for 15 minutes. And I'm comfortable with entertaining some questions, Jamie, maybe halfway through. And so we'll do it that way. But I love it. Okay, I love this this visual. How many of you have gotten a tune-up lately? I got a tune-up about a month ago, or maybe 5 weeks ago. And then I started having some issues with my car, like the oil light went on. And I thought, wait a minute, whoa, what's going on? I thought I just had a tune-up. And then I got another error message that said, your coolant stopped engine. I thought I almost panicked because I was actually driving somewhere and you're seeing these error messages. So the reality is, a lot of times with the cars and automobiles that we have, we can program these times, because the reality is if we don't take care of the car, the engine is not going to continue to go and the car is going to break down. What's interesting, the parallel I thought about is in terms of cultural competency, is that many of us have had cultural competency during our training programs and our education programs, but the ethical codes we follow do require us to continue as lifelong learners. But the reality is then it is contingent on the practitioner prioritizing that cultural competency as well as other competency. Now, we also know that our licensure boards are going to dictate that we do a diversity, oftentimes a cultural diversity and or an ethics requirement for a CEU during our licensure renewal process. But that still gives us a great bit of autonomy to prioritize it. And so what can happen in practice is that we can get old in our skillfulness, we can get rusty, almost like the engine or the car gets rusty if we're not oiling it and we're not taking care of it, or as my car once, the timing belt popped because I didn't pay attention to what the handbook said, that you have to get your timing belt replaced. When I think about that, it's kind of interesting, right? Because do we have a parallel for cultural competency timing? And so the onus is really on us to make sure that we're staying abreast in the field. And I want to encourage you all to continue to look for these opportunities. It's kind of interesting if you haven't heard this song. This is from way back when. Aretha Franklin had a song called Zoom. And she's talking about a lover, but I almost think of that song because I feel like we probably are zoomed out right now. There's so much that's available that we can access, but at the same time, during COVID-19, we're a little bit exhausted from it all. So, just think about this as you think about how you are sort of functioning in the world that you're functioning. I want you to think about the communities that you're serving and what are the community members' cultural backgrounds and realities, and what are some of the needs of the cultural communities that you're serving and the variety of those communities. And I want you to think about that. So we have a poll right now, and if you can just answer and respond to the poll, we're going to just take a quick look and see how folks here are doing. Have you recently assessed your cultural competency? It's looking pretty good in terms of the numbers, which is great news.
Give it just a couple more seconds if anybody wants to answer.
And it's okay if you haven't, because, a lot of times we have so many demands in our workloads, and when you're providing client care, it's intensive work. And honestly, right now, because of COVID-19 pandemic, practitioners are burning out and they are overwhelmed. They're also experiencing some mental health load and intensity because of everybody else is stressed out in terms of their client load, their families, their communities. It's been difficult during COVID. And so just be gentle as you think about what your cultural competency sort of areas that you still need to take care of, that you need to learn more about this particular racial group or this particular ethnic group that you're serving, or you haven't updated your knowledge in terms of theoretical models or what the science is saying. One of the great resources that I think I have on our resource list is tip 59. I believe it's tip 59 through SAMHSA, which is an amazing cultural competency manual in effect that you can download for free. And it's wonderful because it gives you a lot of tools that you can use in your work, but it also gives you assessment tools that you can use as an agency as well. I'm going to introduce one, but we'll also have that as a resource. So take a look at, it looks like we've got some good numbers. About 71% of our practitioners today and preventionists and others who are on this training have been able to assess recently. And for those of you that haven't, close to 30%, I want to encourage you after the call to go ahead and take a few minutes to complete the cultural competency assessment. Okay, so we're going to just move on from here. All right, sometimes it will freeze, so hold on. Okay, here we go. So it's going to continue. All right, so here's a cultural competency assessment I want to introduce you to. This is a great tool. This is called the California Brief Multicultural Competency Scale. I use this scale a lot. I teach, as I said, and I use this particular cultural competency assessment in the first class before we actually start the education for the learners. And then I give it to them again at the end so that they can assess. We have like a baseline of what your cultural competency is, and then we measure it again after you have gone through like in my case, a 15-week. California Brief Cultural Competency Scale, it's a tribal communities, and to learn, because even though I don't provide, I don't have a lot of tribal members that I'm providing treatment to, I need to learn more about them. I need to increase my knowledge, my awareness culturally, so that I can look at what are going to be the nuances as I broach and explore culture and their lived realities, emotionally, mentally, spiritually, financially, etc., physically. And so this is one tool. Now you'll have an opportunity after today's session that you can just click it on and it will take you to the scale, but it will also give you the scholarship that you learn about the scale. This particular assessment was normed with a group of practitioners in California. And if you've never been to California, you'll know that it's very racially and ethnically diverse. And so the norm group are ethnically diverse practitioners that are European descent, African descent, Latinx, Asian descent, Native American and indigenous persons, and even folks who are multiracial and biracial and identify in those ways. And so this is one recommended tool. So the goal with a recent diversity class that I taught, and this is a course I teach at Hopkins, Johns Hopkins University here in Baltimore, and I'm teaching undergrads presently. And I want to just show you how I use this tool, just to give you an example. It's not the same, of course, with practitioners, but it is a current group that I'm working with, and I'm in my second teach with a new group. So the goal is that you can use this assessment to assess yourself as a practitioner. As I mentioned, you can also assess your staff at the agency level. And then the goal of doing this is that then you can develop ongoing development based on your assessment of your team. So that, for example, there's 4 subscales that we're going to look at next very briefly with this particular assessment. And if you see that your team is low in an area, then you can develop a strategic plan for professional development to help your team as a agency clinical director or leader, or if you're a member of a team, you want to recommend it to your agency team or division, so that you can identify where are the areas that we're strong in, where are the areas that we still need more growing in. Okay, so here's an example from the recent class. The first subscale is how much cultural knowledge do you have individually and as a team? What's your cultural knowledge? Am I familiar with sexual orientation? For example, the range of sexual orientation that I just taught on Monday, actually. And am I familiar with gender and what gender is? Gender, non-binary gender, cisgender. Am I familiar? On Monday, we're going to talk about classism and the class worldview model. What happens with material poverty and how many gamblers and people who are addicted actually are experiencing gambling disorder, not because they just wanted to have a gambling disorder, but they were gambling as a way to take care of their families because of financial disadvantage. And so, what's your cultural knowledge when you look at that? Then the next subscale looks at how sensitive are you culturally. If I'm working with a person who's gender non-conforming, what does that really mean? And as a heterosexual African descent woman who identifies as a woman, what do I need to be understanding in terms of my sensitivity? Am I able to negotiate a respectful relationship with my gambler or my person who's struggling with mental health concerns? And then the area that we usually have spent the most time with is cultural awareness. What's your level of cultural awareness? And what we're talking about in terms of cultural awareness is not cultural awareness about the other. We're talking about our own as an individual, as a human being. So for me, my cultural awareness is I'm 6'2.5" feet tall. That's an important part of who I am. I'm a tall woman. It was very difficult for me to find clothes that I could fit back in the day until they now make it more available. And I can order pants that aren't high waters, is what they used to call it when I was growing up, because now, they're more accessible in terms of the marketplace for people who are tall. But I'm also a person of African descent. As I said, I as a heterosexual and I identify as cisgender, but I also have a faith and spiritual identity that's important to me. I am a middle class person, but I come from a working class family, and I didn't have a lot of material wealth, but now I have more resources. But because of my background and how I was socialized and how I was raised and where I find kinship, it's no surprise that in my heart and in my mind and spirit, I'm really for the person that doesn't have a lot. And I'm always trying to help people who need more support because I came from not having that. The other area is non-ethnic, and then you get a total score. So you'll see with the group that I just taught, the numbers did increase. And so this is what you're hoping for when you're using an assessment scale like this. So I want to present a case. Let's talk about a case now. And I'm going to come back to this case as we introduce the two models, all right? And this could be a particular, an example of a case that many of you may have in your work as mental health providers, gambling, counseling and treatment providers, as well as addiction professionals. Kim is a 65-year-old African-American gambler. This is a call that I received. She calls the 1-800-GAMBLER helpline, and she reported wanting to stop gambling. She has gambled at the casino for 20 years. She reports her gambling problems are approximately 5 years. Kim states that she plays the lottery, the casino slots the slots for about 20 hours a week. So think about that. You have a person that's spending about 20 hours each week. Imagine that. That's like a part-time job, right? She's married and she has 2 children. She's also employed and she works as a geriatric assistant. She's in debt approximately $20,000 to $30,000. Now, when we ask the gambler how much debt they have, the numbers are underreported. So you probably want to add another $10,000 to $15,000 to what she really is in debt for. Kim states that she has marital conflict. She uses her savings to gamble with, and she is struggling to pay bills now. No surprise, right? And so I also learned that Kim is unfamiliar with Gamblers Anonymous and Gam-Anon, and she is interested in seeking therapy with a gambling counselor. So the peer recovery supports that we have in the community A lot of cultural communities aren't knowledgeable about recovery-oriented systems of care. When they enter our programs, they don't even understand the language, they don't understand the concept. And so we may use these recommendations as if people are really familiar, but people are like Kim, who, if I'm in trouble or if I'm feeling sad or down and out, I talk to my mother, I talk to my husband, I talk to my girlfriend, I talk to the people who are in my community. It's what I say here in Baltimore. When I drive around the city, people are doing their own group therapy in their community. They're not coming to see NAR's agency or Michelle's or any of us. They're doing their own group therapy. They're walking out into the community and they're talking to their neighbor. They're talking to their brothers and sisters or their extended family, their friends on the block or in their rural communities or wherever they function in their suburban. They're doing their own form of group therapy or therapy, if you will, and they're not coming to see us. That's one of the big reasons why we're only reaching less than 3% in terms of gambling treatment. Where are we? Where's the other 97%? So we've got to do more to reach those persons. All right, so let's continue. I'm hoping that we will advance the slide eventually. All right, sometimes when you're not touching it, it freezes. Okay, here we go. And so the first model that I want to introduce you to is Norma Davines. Dr. Davines is actually a scholar, counselor, educator, and researcher at the Johns Hopkins University School of Education. And Dr. Davines and research team created what's called the multidimensional model of broaching behavior. The first original model was developed, and then she has expanded the model, and I will be introducing you to some of the updates. So this update is what I'm going to call update number 1, cultural broaching. And let's define what Dr. Davines means by that. Dr. Davines and the team defines cultural broaching as the ability to broach, and I would say another word because these psychological terms don't really, it's not our everyday conversation language, but how are you able to talk about? How are you able to broach or talk about sociocultural and sociopolitical meanings that clients attach to their concerns? And so because a lot of times we're focusing on the psychological distress, sometimes as cultural competent practitioners, we're not integrating the social political and the sociocultural realities. For example, COVID-19 has opened the curtains wide open to the injustices that we have been able to hide behind for quite a long time. Also to white supremacy and to the economic injustices and the inequities that exist, the social determinants of health, the health disparities. What COVID did is it opened the window wide and it opened the curtains wide. We can't hide behind the draperies, if you will. And so if we're not comfortable recognizing that when culturally diverse human beings are living life, they are part of political systems and social cultural systems that affect their humanity, affect their body, affect their hearts, affect their spirits. And so Dr. Davines and many of us, what we're saying is, let's get more comfortable to talk about it, to actually have conversations about it in your room, in your rooms, and in your settings with your clients. And this includes preventionists too. So when I'm doing community wellness, such as the Urban Radio program that we're gonna showcase next month, I'm talking on the broadcast about what happens with communities that don't have the same equitable opportunities. And so if they wake up every day and in their communities, there are food deserts, there's not healthy food, there's no surprise that they have higher rates of chronic disease and chronic illness, so that when COVID hit, they're dying quicker and they're dying more. And so now we have a pandemic in terms of particular communities that are facing more challenges. We want to talk about it. And so that's the update one with this model, is how comfortable are you in the broaching? And so Dr. Davines and her team is encouraging us as counselors and as preventionists and as agency leaders and as mental health practitioners, whatever your identity is, and health providers, to be very deliberate and intentional in discussing those racial, ethnic, and cultural, REC for short, concerns that can affect your clients presenting concerns. So the question is, how are you able to initiate those conversations? And say in the case of Kim, if Kim starts to talk about her lived experiences as an African descent person and all of the other experiences that she has and the intersectionality of those identities culturally, because it's not just that she's an African descent person, but she's also may identify as cisgender woman. She's married. She also has occupation that doesn't afford her opportunities to make enough money potentially. And so perhaps she started gambling as a financial strategy, and now it's like a part-time job instead of her getting a part-time job, or looking for ways to expand her occupational advancement that would increase her, say, economic opportunities as well. And so that's what we're talking about here in terms of broaching. So this is actually the second poll, and it's funny, Jamie, I had told Jamie that I had two polls, and then I looked at the slides, and then I said, no, it's really one, but it was really two, Jamie, but no worry, we're not gonna actually take this. I want you to just think about it. Do you actually broach the culture consistently? So the question is just for your own assessment, are you broaching it consistently? And so it may be that you broach it in the beginning when you gather intake information from your client to see who your client is. But the question is, during the course of treatment, or say if you are a preventionist and you're providing community-based prevention, are you integrating culture and making necessary cultural adaptations or modifications in your prevention work so that it fits for the community that you're supporting? Okay, so let's look at another example. This is an example of a client that called me for help. I'll call him Jeff. And we have heard this idea and this reality of social cultural reality and social political reality for many Black and brown and visible racial individuals who are driving while Black. I live in Baltimore City, where also one of the counties, which is called Prince George's County, which is about 50 minutes away, had one of the highest rates of police stops driving while Black. So Jeff is a 19-year-old orphan golfer. He is a golfer. He wants to go pro, who works at a warehouse, and he hopes to go pro one day. His parents actually died within 3 years of each other, and he has one brother. He called me for help as he detained overnight driving while Black, and he's traumatized. And so the question, if this is a call for you, and maybe we can pause this, Jamie, to see if anybody has any comments in the chat. Can we process this particular racial injustice and traumatic experience with a caller like Jeff? Or do we do a dance around racism? Do we do a dance around it? And so, you know, it may be, for example, if a clinician didn't feel comfortable with.
It's important.
Oh, Dr. Haskins, you just got muted. I'm not sure what happened.
I am
All
so
right.
sorry. As
There
I
you go.
let somebody into the room, my mouse also muted you, Deborah.
Okay, no
I
worries.
apologize for that. Sorry, everyone.
No, hey, no problem. Did you all hear what I think what I wanted to do? I don't know if they heard, they can read the case, but I'm wanting to pause to see if anybody has any comments about this particular caller. What if this was your case? Would you do a dance around the racism? Would you feel even be comfortable talking about this? And a big part of this, everybody, is that a lot of times in our training programs, depending on where you went to school, you may not have gotten sufficient education and training about how to have these conversations. And the reality is that a lot of people in the world are not comfortable addressing racism in conversation. And particularly say if you're European descent and visible white racially individuals, sometimes it can be uncomfortable if you have not addressed race even in your own identity, because that's part of the privilege of being, say, European descent or white in America in particular, but even in some other countries, that you have the privilege not to even think about race because that's not part of your lived experience as a result of privileges. And so sometimes in our programs, the program has not provided sufficient support as well. And so it's okay if you haven't. What we want to help you do is to look for the opportunities where you can become more comfortable. Just start talking about it, even talking about the fact that you don't feel comfortable. So many of my students say, I don't really know how to do it. And so I'm trying to help them to learn how to do it. But most people, and we're going to see this with the Tucker model, they feel you're more credible as a practitioner and as a health provider when you address your honest experience, like to say you don't really know a lot about it, and that would be okay. And
So
to
Dr.
say
Haskins,
that you're trying to learn.
We have a few comments and then we have one hand raised. So I'll get to the hand raised in a minute, but the comments, how can you dance around? They have a lot to do with racism and trauma. So how can you dance around it when the racism is trauma? As a Black man, I can identify with the trauma. And then this is a topic to be addressed head on because it's his trauma. And then Eileen says, I recently commented at a town board meeting on the supervisor's racial rant toward a Black man. The case was whitewashed. I addressed and it was later reprimanded as well as being wrongly quoted, and my concerns were dismissed. I wish I could have opened with the all white board members were rather culturally. Oh, I can't read. I don't know what that word is.
Okay, culturally competent. Yeah, I think it looks like it got cut off, but let me just say comment to that. And I'm sorry that this practitioner or individual experienced that. And the reality is, particularly if the board, which in this case was all white board, may not be comfortable because one, they may feel that they're the targets, and oftentimes that is very uncomfortable for them. Again, every person has to do the work themselves. And so what we're wanting to do is even to train our boards. And let me just say this, as a president of a nonprofit, I'm intentional about diversity, equity, and inclusion in leadership. And so when we have opportunities, the idea would be to diversify the board, number one, as a leader, because the more diverse the board is, the more opportunities you have to have more voices, and you don't have the situation where you may have homogeneous boards that aren't comfortable dealing with race and, say, culture, because maybe they haven't had to deal with that from their own privileges. So that's a really good example. And so what we want to do is look for supports outside of your organization as well, with like-minded people that can support you and give you the feedback as well as the encouragement, but also to know that you have a right to call out those situations and those racial injustice and social injustice experiences, and to find people who can support you in that. I also want to acknowledge that there are many, a couple of the comments are from Black men on this training who are talking about this is what they have to live through every day. And so we know that people have racial microaggressions. And what are these? These are insidious daily insults and assaults on your mind, on your body, on your spirit. And so it's no surprise that many Black men and even brown men are walking around with a lot of rage internalized because they are in a world that doesn't see them, doesn't count them, that treats them as invisible. And then when they respond to the injustice emotionally, they say, well, you're an angry Black man, or you need to calm down. Sometimes even in our clinical work, when they speak out, we may not feel comfortable with the level of their expression, and we may silence them too. So we want to be careful about that. And that's why the cultural competency is important, because when you increase your knowledge about those lived conditions, then it makes you culturally empathic and allows you to create a safe space so that all of your folks, whether they are practitioners or whether they are consumers in your programs, know that they can express how they're feeling. Let me give you a quick example and then I'll move on. I remember I was asked to be a reviewer on a NIH gambling addiction funded. It was an evidence-based program that was trying to get funded. And in order to pass the NIH funding peer review process, they flagged them and said that it wasn't, the protocols that they were using were not culturally diverse enough. And so this was a particular gambling addiction evidence-based initiative that was developed for the spouses of gamblers. And what they were doing was educating the spouses or even partners of the gambler to understand gambling addiction and to learn how to set healthy boundaries in the relationship and to, support them cognitively, emotionally, etc. And so when they looked at the scripts, if you know about anything with cognitive behavioral model, you have a script, because it's manualized treatment. And so when they looked at the scripts, they said, well, this doesn't look like the whole program is lacking cultural diversity. And so I was bought in. And so I remember looking at the scripts and I said, wait a minute, we have a problem here, because Black women and people who are maybe culturally diverse don't have conversations like this when it goes down in the family. They're not going to say, honey, I'm really upset that you did this. They're going to say, wait a minute, hold on. What's up? They're not going to talk like this. Okay. And someone is also remarking, this just happened in treatment court yesterday with the participant. All right, so we'll circle back, everybody. So I'm going to move on because I still have a couple of the other model. Now, what we do if a person doesn't feel that we're comfortable in the space to broach culture, which includes race, ethnicity, and culture, and the intersectionality of it, what has happened is it's been linked to cultural miscommunication. They don't feel we understand them. They don't feel heard. And then what do you see? We see higher rates of premature termination. A lot of times what we'll say is, well, maybe they were unmotivated or they may have relapsed. But in fact, what may have happened is if they don't feel that this is a safe space, why do I want to stay in a space that's not safe, that sees me? If I'm invisible in this space, I'm not going to waste my time seeking treatment, even in this space. So Dr. Davines and our research team, and I'm trying to, let me just minimize this because now I can't see it. The goal is to enumerate the different orientations that the counselor may have. And so I want you to look at this continuum and try to see where you fall on the continuum, okay? The first style is the avoidance style of broaching. This is a practitioner that typically ignores the significance of race, ethnicity, and culture. So say when Jeff comes in, this avoidant practitioner doesn't feel comfortable, maybe because the practitioner hasn't even reflected on the practitioner's cultural identities and doesn't see culture as being really significant, sees that it's all about, you just need to recognize that happens in America to a lot of Black and brown individuals, and it's just part of the territory. And this person avoids RAC. They don't really talk about the racialized concerns, and they redirect the client's attention to more generic, or what we call etic topics, universal topics. So for example, here you see in front of you that Jeff shares his driving while Black. The gambling counselor in this case feels uncomfortable saying the case if it's a white therapist, and doesn't want Jeff to perceive her as racist. So she has also limited experience with racism and just focused primarily on what was the outcome of missing work. Might even say, let's talk about your grief and loss. I can help support you in that, which is not why Jeff called for help. And their absence to even help him work through the life challenges like this driving while Black. So that's one. That's the avoidant option. Okay, the next one is called isolating. This is a practitioner that does a little bit more broaching, but minimally, but does it quickly, and really broaches to be more obligatory. Maybe has learned you need to do it because it's ethically required, but really doesn't spend time with Jeff talking about if Jeff really wants to process this, and to talk about, well, what is it like for you every day when you're living in a world that constantly is targeting you as a Black man. Then you have the continuing and congruent broaching style, which the practitioner might broach mechanically, really lacks the verbal dexterity, the scholars say, to talk explicitly about, say, Jeff's or your client's RAC concerns. And then moving up the continuum, you're getting to more sophistication. And so this is what is called the integrated or congruent. Like, say I'm my Asian descent intern who hasn't had a lot of experience with Black males or African descent individuals and communities. And so I'm trying to help my intern function more in an integrated and congruent. And it might be to say, listen, I'm Asian descent. I don't really know a lot about Black culture. I haven't spent enough time. I know a lot about my own Asian culture as a Korean woman, but I want to learn more. Tell me more. And so I don't want it to come across that I'm not familiar, and I don't want to be racist. I'm learning to be anti-racist, but I want to hear from you, and I want to be genuine in how I support you. And so that's what would be a more integrated and congruent style. And then the infusing style is where you broach RAC concerns with clients by maintaining a social justice focus that addresses what are the barriers that your clients and the communities experience, or people like Jeff, that impede their progress as well as their well-being. And so what we're doing is real multicultural and social justice counseling interventions. So if I'm working with Jeff, and this was actually a former client of mine, we spent time processing the traumatic experience if he wanted to emotionally. Sometimes our clients are so emotionally overwhelmed that they can't really do all the emotional processing. But in this case, Jeff needed to and wanted to. And so because I am a multiculturally infused clinician on a personal level, on a human level, as well as a professional level, I could talk out loud about it with Jeff. And I talked about the trauma, racial trauma. What was it like? And I would talk about with Jeff, that is unacceptable. I'm not going to use clinical conversations. I'm going to call it out for what it is. It would be similar if I have a client who was raped repeatedly by their family member. I'm not going to sit there taking notes to say, what I hear you saying is that you suffered sexual rape by your, I'm not going to do it. I'm going to say to my client, unacceptable. My heart breaks for you. Just hearing you describe the pain that you had to endure. And I want to talk about what that experience was for you. I want to help you breathe through it. And then I want to help provide you some resources to help you feel safe. But then we also had to talk about how we had to address him calling out from work and him not feeling safe to even share with his boss what really happened. Okay, because he doesn't even really feel safe in this manufacturing job. Okay, so there's an assessment, there's a survey that you all can Google survey. And what the researchers found was that there was support for these four, the broaching construct. What they did say is that the isolating category didn't emerge as distinct, likely because it's very similar to the avoidant one. Okay, so not that anybody, you may not really care about it. I'm a researcher, so I love reading that stuff. Okay, so let's return to the case of Kim. So during the intake, I will ask Kim, I will use a standardized RAC invitation with Kim and ask Kim, are there cultural identities that are important for you, Kim, that are important for your family, that's important for your community? Also, if you have a communal attachment, which many individuals may also share. So Kim shares actually that her neighborhood has a lot of poverty, that she struggles every day to make a livable wage as a GNA with her husband, and that going to the casino helps her feel hopeful and alive. So I explore with Kim how her occupation, while it is rewarding for her, it doesn't pay sufficiently. And in what ways does her race, her ethnicity, and her culture also affect her identity, her life in both positive and some challenging ways? And then a goal for me as her gambling counselor is to invite the safety, support, give support, and to problem solve along with the gambling recovery goals and the treatment plan. So basically what I'm saying to us is we have our gambling treatment goals, and then side by side, we have our race, our ethnicity, and our cultural goals that go along with that. And I actually do what we are recommended to do with the DSM-5, although I'm not a fan of the DSM-5, just because this is a classification system that has pathologized many individuals and communities. However, we have it, it's the way we do classify it, but I want to use a strengths-based model. But one of the good things in the DSM-5 is there is a cultural formulation. And what is that? We're asked to write one paragraph summarizing what are the racial, ethnic, and cultural issues and identities and needs for every client, affected other, and the communities that you're supporting. And I would include that in the treatment plan. So, you know, that's a requirement when I'm supervising my supervisees, they have to have that. And the last part of the cultural formulation says, what is the overall cultural plan for your work together? And you guys can Google Scholar the DSM-5 cultural interview, and you will find, I think it might even be on the resources here. So we'll take a look at the end. All right, so let's just keep going, because we're going to get to a place where you get to ask some questions, and I want to get through the next model. Now, some counselors mistakenly assume that one's broaching effort is designed to focus exclusively on issues of racism and discrimination, and Davines and the scholars, as well as myself, say that's not all of it. So while race and discrimination do impact many ethnic and indigenous persons, they're not the only REC encounter that people have. And then we also, as I said, have to make sure we understand that we are looking at the intersectionality of those experiences also. And so in the new domains, what they introduced are these 4 domains, and I'm not going to be able to spend sufficient time with each of these, but take a look when you are able to. You can do a little bit more reading about this, because you'll see under A, in terms of intro counseling, this is the new update with the model by Davines et al., is that the counselor tries to negotiate interpersonal processes that govern our relationship. So it's similar to what my Asian descent intern said. We're looking at her identity in terms of race, ethnicity, and culture. We're also looking at the clients that she's working with, and we're looking at the viability of the therapy relationship to see, are those differences as well as similarities what does that create in the counseling process? All right. And we're using counseling immediacy, like the here and now, to look at how we can respect the client, how we can negotiate mutuality, connect, etc. The intra-individual domain permits the client to address the intersectionalities. Like that intersectionality model is by Crenshaw, and who was a legal scholar, and looked at power and oppression. And you can Google scholar that in your own time, but it looked at the fact you're actually at an intersection in the street. You have race on this road side, you might have culture over here. And the question is, how do they intersect? And each intersection, each of those identities may have experiences of power, oppression, privilege that influence those identities. Okay, so we're going to just move on. And like I said, you can read the last two when you have time, because I've kind of touched on some of these, like looking at how you can have conversations out loud about microaggressions, for example, and structural inequality. So let's return to Kim and just think about it with Kim before we move to this next model. How could you broach Kim's identities and integrate those identities with her lived identities and how they influence her motivation to gamble? Type into the chat if you can, and let's have Jamie will read out loud, because my question, if we apply the model to the case of Kim, in what ways does gambling offer her a false sense of power that she feels lacking in her life? As a Black woman, as a GNA, living in a community with multiple disadvantages, there's a liquor store in every corner, there's drug dealing going on, and unsafety, food deserts. She's married to a man who's treated as invisible. And how do these stress factors impact her marriage, herself, her family also? So just type into the chat and let's see if we can get some feedback. If you were working with Kim as your gambling counseling client, what would you how would you broach what she's presenting along with her gambling addiction?
Give everybody a few seconds to think about it while Dr. Haskins grabs a drink.
Thank you.
Anybody want to add anything about how you would broach the situation with Kim?
All right, maybe they need just some thinking time. We can come back to the case at the end if we have time. Okay, so we'll just continue on. May need a little more reflection time. Okay. All right. Well, basically, I give you the script, so I'm kind of giving you an answer. So I would say something like this with Kim. Kim, you're a member of multiple communities that have significant value that's important to you, but you're on the margin it sounds like with each of these communities. You're on the margins as a Black woman. It sounds like you're also on the margins occupationally as a GRC or GNA, I meant to say, working in a healthcare environment that doesn't always reward your value, especially with pay. You don't always feel a sense of complete belonging and acceptance in any community, potentially, although you identify with all of them. So my goal with you today, Kim, and our work together is I want you to feel like, how can we make some changes using a strength-based model? How can we look at some ways to understand why you gamble? You know, the gambling is a way it sounds like it potentially may be a way to relieve financial distress, but it could be a way for you to relieve emotional distress and also cultural stresses. And so we're going to be able to focus on those. All right. So the next model, and this is an update, is the patient-centered, culturally sensitive healthcare model. I love Dr. Carolyn Tucker's model, as I said early in the beginning. What she did is she created a literature-based, testable, patient-centered, culturally sensitive healthcare model. And in short, what is this? what Dr. Tucker and their team did is oftentimes we have asked clinicians and preventionists, what is cultural competence to us? And what is it to our field of social work, psychology, clinical counseling, medicine? But what we haven't done is ask patients or clients themselves, how do you view and assess your practitioner who's providing you care? What do you believe is culturally patient-centered, culturally sensitive healthcare? And so what they did is they asked consumers who were experiencing low incomes, racially or ethnically, particularly people who are culturally diverse and use community. And so this is this research. And these are some of the questions that I would offer for you, because here's the thing, is that when you ask your patients or your clients, cultural competency is not the same as how we perceive it. Okay. And so these are just some questions that I would offer for you to share with your clients right at the outset of therapy or accessing treatment with your facility. Or if you're a preventionist and you're providing prevention support in the community, you might ask, what does or could we do to make you feel more comfortable? And what might we do that makes you uncomfortable? Okay. It might be that you've had even prior experiences with therapy. Like, did anything happen that made you uncomfortable? Tucker, this model is asking us to gather that information. What makes you feel more trusting? We usually ask that. How can you feel more trusting of this relationship or the services here? What could we do to show you respect and be sensitive to your needs? What could we do to show you that we're respectful, specifically, if you can name it? What can we do to become better at helping you from your racial, language, or cultural background? And what are some physical characteristics even of the clinic environment that might make you feel comfortable? So for example, years ago, when CORE down in Louisiana opened the first gambling disorder treatment, I trained the staff, amazing leader, Janet is an amazing leader down there, but the original leader was Reese Middleton, who is deceased a couple of years now. He was amazing. He flew me down, and my mentor, Joanna Franklin Robertson, we went down to train up the staff. And so they had moved into a new house that was going to become, or they were renovating this house that had been donated to them to provide treatment to gamblers and gamblers who didn't have any money even. And when I looked at the aesthetics, one of the issues that they said is that many of the clients didn't feel comfortable because it was too nice. It was too clean. They felt this was really not something they were used to. And so it may have been too sanitized. It may have felt really uncomfortable for them. And so what I also talked to them about was that it lacked cultural diversity to make it feel comfortable. Like your artwork. Are you providing magazines or books that are culturally diverse? Are you using, you all see behind me, this is in my office, because I'm a person of culture. And so I have cultural artwork. I used to work in a pastoral counseling agency, which was a spiritual faith-based agency. And they had the picture of the 12 disciples that were all white men. I said, that's a problem. We need to take that picture down, and we need to find a picture that's culturally inclusive, because this is an ecumenical agency. How are they going to feel invited if all they see around them is some people from outside of their community? So that's what we're talking about with the physical characteristic. One of my former interns said that the agency that was an addiction agency, the structure of the agency represented like they were actually in prison. It was actually functioning more like a legal jail system, just in how the infrastructure was set up. And so I don't think that the treatment providers intended that, but what was happening is that the rules, the policies, the system, the physical environment really looked like and felt like and was experienced like you were back, for those who were in criminal, were locked up, were back in a prison system, or a jail system, or a prison system. All right, so let's keep moving. So these are three consistent themes that Dr. Tucker identified in this update. And we'll be getting ready. I think we have about, looks like 10 more minutes, okay? And then we'll start the Q&A. That a lot of people, patients, have said that they feel more trusting of our health services because they look at positive personal qualities and people skills. And when they look at the different racial groups, the different groups identify it credibility in different ways. So African American respondents, they feel respected when you shake their hand. Now, of course, we know with COVID, we're not doing that fist bump. I mean, not fist bump, arm bump, elbow bump, but introducing yourself, using their first and last name, and particularly older adults, not just calling them by their first name, but even asking them, what name do you want to use? If they have a Afrocentric name or a cultural name, you know, making sure that you ask them how to phonetically pronounce the name. That's how they feel respected. And so, whereas some of the other provider staff member behaviors that were common across the African American and Hispanic and non-Hispanic white patients were, they identified being listened to, you being thoughtful, showing empathy, taking time, not rushing me through. One of my gamblers who said, I want the clinician to have a sense of humor. I want the clinician to be able to laugh. I don't want to come and receive services with someone who doesn't even seem like a normal person, like they can't even laugh. So another characteristic was individualized treatment. Now, interesting, only African Americans reported not being treated as a guinea pig and having specific medical knowledge relating to African Americans, while the Hispanic and non-Hispanic whites reported not having too many patients being important. White patients were doctors from other countries. Let's see, effective communication, also identifying language barriers by non-Hispanic white patients in cases where doctors from other countries, they didn't feel spoke English clearly. And so that was a concern for them because it made it difficult for them to understand what the doctor says. So if you do have an accent, we just have to take more time to explain to people, or just being alert to the tone and the accent. Technical competence was also identified, and here only African American patients, there's a typo here, my apologies, said focusing on the problem, simplifying treatments and avoiding mistakes, whereas the non-Hispanic white patients said referring the patients to specialists that the patients help identify as knowledgeable. So basically what they're saying here is they want us to be able to incorporate specialists that are knowledgeable about their lived experiences, and they want us to be confident. Okay, so let's see how we're doing with time. I think we have about 7 more minutes, Jamie. So, you know, some of these we're already aware of. I spoke about, you know, some of this already. I did want to show again the differences with the Asian American patients. They did find that the rate of health service usage and treatment is very low, related to other racial and ethnic groups. And we had Dr. Yen, Y-E-N, who was on our board for a short time as an Asian descent psychologist. And it's kind of interesting. I have this picture here on my shelf. And Dr. Yen, I'm going to just show you guys this. You see him, he's in the middle. And he actually was trained with Dr. Skinner. That's Dr. Skinner over there on the other side of him. And so, wow, I was like, wow, he gave me this picture. I was like, whoa, wow, you trained with Dr. Skinner. He said, you have to emphasize prevention, prevention, prevention with Asian descent culture. They're not going to seek treatment. They're not going to come in. You've got to speed up and increase your prevention more, because they're not going to be that excited to come in for treatment. And so just take a look at this, because the different groups do have different expectations. And I did have for you to read, and you can see the differences with the Latinx community. So this particular model has been used with African descent, white patients, white Latinx, and Asian descent. And what's interesting is that the implications are the same across the board, that respect is going to be interpreted in different ways. But say in the case of the Latinx, if we can't speak their language, it's no wonder they don't seek treatment. Why would I? And so the Latinx, one of the findings was that they preferred the language. They want you to speak the language.